Uh, Good morning, good afternoon, good evening, colleagues. My name is Michael Waweru-Maina. I want to welcome you for this session. And for those people who are joining us from the French-speaking countries, or if you'd want to follow this presentation in French, please feel free to click at the bottom of your screen and select French language. We have been having these M&E subcommunity of practice sessions. We started them back in February. And so far we have had a number of sessions. We have looked at the fundamentals of M&E, looked at the framework for laboratory program. We went ahead and looked at the various indicators that are used in lab program. We looked at how you establish various systems and dashboard and how you need to triangulate your data for program monitoring. Today, we'll be looking at the quality of our data, and we are privileged to have two presenters who will be making the presentation today. And we basically want to look at how do you assess the quality of viral testing data. The presenters that we have today are Hiwot Haile-Selassie. Hiwot is an infectious disease epidemiologist working as a consultant for the last 4 years in the Strategic Information Analytic and Use team in WHO Geneva within the Department of HIV, STI, and viral hepatitis. Her work focuses on HIV patient monitoring, data quality, support, her work focuses on HIV monitoring, data quality, and ARV toxicity surveillance, where she is involved in producing technical guidance and tools and supporting countries with implementation. She coordinates and then we'll get to hear a little bit more about the country experience. And for that, we have Faith Gary. Faith is a program officer who works within the Ministry of Health Kenya. She has extensive experience in data management, program management, and also has experience at various levels of the healthcare system. She is currently working at LabCoP, where she serves as the lead health information system as the lead in the health information system section. She'll basically be sharing on the country's experience in implementation of viral and data quality activities and strategies in Kenya. Without further ado, I would want to welcome Hiwot, who will make the presentation for the first 20 or so minutes. Then you're going to have Faith, who also make a presentation for around 20 or so minutes. Please remember to put your question in the chat box, and then we shall hand the question towards the end of the presentation. Thank you, and over. Please, I hand you over to Hiwot. Hiwot, please.
Thank you, Michael. I hope you can hear me well.
Yes, we can hear you.
Good. Okay. So perhaps I could ask everybody to put themselves on mute. I think there's a little bit of background noise. Okay, so I'm going to just share my screen. It's a real pleasure to be with you today and to have the chance to share some of the work that WHO has been doing in collaboration with partners looking at data quality for viral load testing. So let me just move this. So just to say, in the next 20 minutes or so, I'm just going to set the context and touch on some of the issues around the importance of data quality and some of the common data quality challenges that we see with viral load testing. And then I'll spend most of the time going through the recommended approaches for viral load testing data as set out in this joint module that WHO-UNAIDS-PEPFAR Global Fund have developed. And it's a very extensive module, and I won't have time to go through all the details with you today, but we will share the link. It's on the WHO website along with all the annexes, and I'll just try and highlight the key aspects of the approaches and the tools that are available for country use. And then I'll conclude with just talking a little bit about how to follow up on data quality assurance activities to get us thinking about long-term data quality improvement. So in terms of the context, I don't think I need to say too much about the importance of data quality, but just to say, I think there's been growing emphasis and appreciation from all levels, from ministries of health right up to partners, about the importance of having good quality data, primarily to improve patient management and outcomes, but also to strengthen programmatic impact for procurement and supply chain management, for accountability, but also to enable performance monitoring. And so as we're working towards the 95 targets for HIV testing, treatment and care, it's particularly important to have accurate data in real time to see where the gaps are in service delivery and how to close them. And so I think there is also an appreciation that historically, in terms of our data quality assurance and strengthening activities, there's been a focus on HIV treatment. And I think we now kind of come to appreciate that we need to do much more along the entire cascade of HIV services. So from testing to treatment and right through to viral load suppression as a key outcome of treatment. And so that's why there's a huge push now to really ensure that we have accurate and importantly timely viral load data with results available, not only for enhancing program impact, but also improving patient care and outcomes for people living with HIV. So with that backdrop, in 2018, WHO convened partners to develop a national data quality assessment tool, which was focusing on treatment. And so this was nationally representative assessments that are designed to enable you to assess and reset your ART numbers if you needed to. And then we sort of had a recognition or realization that those serve a time and a purpose, but more importantly, what we need to be thinking about are routine activities that can be embedded within programs to strengthen health information systems. So within that context, we came together and released last year a module, which is a supplement to the ART tool, which is setting out the different routine activities that can be implemented periodically in a sustainable fashion to really strengthen the viral load testing data and the HIV patient monitoring systems that generate the data. Hi.
I'm sorry to interrupt you. Please slow down a bit for the sake of the interpreter.
Oh, my apologies. Okay, yes. So moving on to the objectives of the module, I think there's not too much to say. They're shown here, but just really the module is designed to enable the rapid assessment and the verification of both the quality and the coverage of viral load testing data. So looking at really all the elements or dimensions of data quality. A second objective is to be able to assess the bottlenecks to improving both data quality, but also data flow, and to feed into the development of strategies to address one of the fundamental challenges, which is around the delays of the viral load test results. And then ultimately, that's with a view to develop and implement key remedial actions to address these challenges, the root causes, and to strengthen the overall data system so that we don't continue to see them time and time again. And all that is with the objective of obviously enabling the rapid use of viral load testing data to improve patient care. And some of the examples of that is also to be able to support implementation of differentiated care for stable patients, or to support the management of patients with high viral loads. So those were the objectives. So moving on to some of the common challenges, I think many of us you who are on this call will be really familiar with these challenges. So at the programmatic level, one of the issues that we're struggling with is to understand the representativeness of the viral load testing data, to be able to interpret the indicators that we have on viral load suppression, because routine viral load testing might not be provided to all facilities or to all populations. We're also seeing significantly delays in the timely transmission and in the receipt and in the use of viral load testing data. So at the time of service delivery, when we're having those patient encounters, making sure that the data is available for effective management. A third key challenge that many of you will probably be facing at the country level is this whole issue, particularly with viral load testing, is inconsistencies in the different data sources that we have. So at the facility level, we have the patient, on the patient side, or the patient records rather, we have both the paper-based and the electronic records. And then we also have the laboratory information systems as well. And then at the aggregate level, we also have the DHIS2 with the viral load suppression indicator. And very often we find discrepancies with these, which can be problematic. And then at the program management level also, I think we're also struggling to have a lack of disaggregated data on the indicators for viral load coverage and suppression. So with all the disaggregations that we want to see by sex, by age, by key population. And so some of the responses that are outlined here is what this module is aiming to address. So, so being able to assess the completeness of the viral load data. So that's why viral load coverage is a key priority indicator within the WHO guidelines, so that you can then use that to interpret the viral load suppression indicator. Also, this module is attempting to support countries to assess the bottlenecks that are delaying the return of results, so that you can then develop strategies to improve both data flow and improve patient care. And then some of the data quality checks that we've included, or the cross-validation checks, is really this idea of comparing the different data sources to see if there are inconsistencies. And if so, then what is the origin or the source of these inconsistencies? And then the last point, I think, not directly addressed by this module, but something to think about, is to look into country data systems to see if they're meeting our needs for disaggregated information. And if not, then can we leverage the activities or the opportunities that we have with tools being revised or systems being updated to ensure that we have those, so we can identify the gaps in service delivery for specific populations that are left behind. So I'm going to briefly try and take you through the module. There's a lot. So as Michael was saying in his introduction, I know you had a detailed webinar focused on developing M&E frameworks for viral load testing data. So ideally, we'd want to ensure the data quality for all these indicators, but recognizing that resources and time do not really enable us to target all the data elements and indicators that we'd like. There is a need to prioritize, and so we're suggesting that the viral load suppression and testing coverage indicators be given priority for data quality assurance activities. And that's to say that's the minimum. We're also suggesting, given the importance of the turnaround time of viral loads, this should also be assessed to make sure that we have timely data for both in terms of data assurance, but really the minimum is viral load suppression and coverage. So moving on now to the implementation. I'm not going to go into the details. This is just a sort of visual representation of the implementation steps that we'll all be familiar with. So, and regardless of what activity is chosen, more or less the steps are the same. And so the 2 points I'll just focus on here is to say that in this module, we've tried to include standardized tools for the different activities, which countries can adapt for their use. And we're really suggesting and recommending, however, these be pilot tested to make sure that they address the country specificities and are fit for purpose. And then really what we've tried to do is give a lot of attention to the last 2 points, which is about reviewing the outputs of the data quality assurance findings with the facility and lab staff, including management, as part of the outbrief, and really having that joint discussion and ownership to then develop the system strengthening plan with the remedial actions to address the data quality issues. So that's the implementation, but now I'm going to just quickly go through what's included in terms of content in the module. So you might be wondering, well, what's new? Because actually, as I go through the options, you'll see that many of the activities are fairly familiar, and countries I'm sure are already implementing these. So really the thinking was to have consensus across all the key partners so that we have the same tools. I think we're all very cognizant and aware that at country level, it can be sometimes challenging with different partners using different tools for data quality assessment activities. So what we've tried to do is standardize and harmonize these so that across Global Fund, PEPFAR, UNAIDS, WHO, we're using the same tools, we have harmonized approaches, and we don't have duplication of efforts. And it's easier for countries then to be able to compare the activities and the results as well. So if you have partners in one area supporting, one specific districts, and another partner, that the methodology and the approach is the same. So that's really the what's new part. So I'll just go into the menu though. The menu it's designed to be a menu in the sense that countries can pick and choose the activities that are appropriate for their context in line with their long-term data quality strategies that they may have. And so what we've tried to do is to set out and give you an overview of what's included. So what's a description of the activity, the strengths, limitations, and some implementation considerations. So the first activity is one that you be fairly familiar with, and that is routine data quality assessments. So this is where the primary activity is focused on verifying and counting, or recounting rather, the indicators for viral load and suppression. So you go into the facilities of the lab themselves and you attempt to recalculate the indicators for viral load suppression and coverage.
Hi.
Hi.
I think you are still moving a little bit fast. I am getting a comment from the interpreter. I'm sorry about that.
Okay. Okay, so I can go slower, but just to be cognizant of the time, so it might mean that we run a little over.
That I think if we do another 5 or so minutes, that's still fine. If we go over by around 5 minutes, I think it's still fine.
Okay, so I'll go a bit slower. Apologies for the interpreters. So as I was saying, so really the primary activity for routine DQA is the recount and verification of the viral load indicators and comparing that with what the facility or the lab reported to the Ministry of Health. And so that's the main activity. And then there are a number of secondary activities, including data completeness checks and cross-validation checks, where you take a sample of records and you compare them from the different data sources. So from electronic medical records, or from the laboratory paper forms, or from the viral load databases. And that's with a view to determine the consistency of the way that data elements are reported across different data sources. And so the benefits are shown here in terms of the strengths, and this includes, enabling mentoring and on-the-spot feedback, as well as the development of site-specific action plans to address data quality challenges. On the limitations, it's obviously more costly, time and human resource intensive. In terms of when you would think about implementing this particular activity, it's really where there is a desire or a need to verify the reported indicators for viral load. And it can be done with partners, or it can be externally, or it can be coordinated and led by ministries of health, or both. And the frequency that we're recommending is semi-annually or annually. So that's very quickly an overview of routine DQA. I won't go into the implementation steps, but just to say there are tools for each of these steps. So starting from obtaining consent. And I will just in the next few slides show you those tools that are available for country adaptation. So we have an annex or a tool that's available to assess data flow and bottlenecks. And it has a series of prompting questions with space to sketch out the data flow. And this is helpful to orientate the assessment team so they understand how service delivery is organized within a facility, how the data flows, to then be able to identify the gaps and feed into the recommendations for the remedial actions. So that's one tool we have. Another tool that we have, again, that we've all come together as partners and have consensus on, so this should hopefully streamline implementation at country level, is an actual tool for doing the recount and the verification of the indicators. So there's one tool for viral load suppression and another for viral load coverage, with detailed space for all the different disaggregations for age and sex and pregnancy and TB and key population. So if countries are able to go down to that disaggregation, there's space in the tools to allow that. And it also has a section to look at the methodology of how the indicators were calculated, as that can be helpful in terms of understanding where the sources of the data quality challenges come from. So those are those two tools. So that was very quickly routine data quality assessments. There's more description of the methodology in the module itself and also in the 2018 tool. So I'm now going to move on to the second option that we have in the menu. And again, it's an activity that many countries are already implementing. So here what we just try to do is to make sure that we have standardized tools for this. And so this is data quality that's done, or monitoring that's done during supported supervision. So this is leveraging or building on the existing supportive supervision activities that countries are already implementing. And so it means at the same time as we are assessing and going in and looking at service delivery and quality, we can also look at data quality. And that's beneficial because sometimes there's a very strong relationship between the two. So you will see from the description, it's actually very similar to a routine DQA. You're doing the same data completeness and consistency checks. The only difference is that you're not going in and recounting and recalculating the indicators, and that frees up time to then do the service delivery assessment. Many of the strengths are similar to DQAs, and the criteria for selection is really if you're really wanting to jointly look at service delivery and data quality. And given that you're not having to recalculate the indicators, this gives a bit more time, and so it can be done more frequently along with the supported supervision activities that are already planned and happening in countries. So in terms of the limitations, obviously it's not as extensive or as in-depth as the DQAs. And we have the frequency here that we're suggesting, which is twice a year. Just to highlight the two tools that we have, again, these are agreed by partners. Annex C is a short abbreviated tool that allows joint assessment of service delivery and quality. I don't have time, unfortunately, to show you what goes into these, but in addition to looking at all the service delivery areas, it also has built-in checks around completeness and consistency of data. And actually, those are the same between the two tools, but Annex D is a much more detailed, longer tool. So that goes much more into the clinical management and the laboratory issues, and is set up in a similar checklist form with scoring. And it's quite a useful tool that we feel that countries can adapt and use for their context. So that was data quality monitoring via supported supervision. The third menu, or the third activity included in the menu, is data quality monitoring that uses a sampling approach called lot quality assurance sampling, or LQAS. And this is borrowed from the manufacturing sector. And it's, again, doing data completeness and consistency checks. But you can say the benefit of this is that it's a fairly quick and inexpensive approach to data collection. So you can use smaller sample sizes. And the idea is that you're targeting lots, which are a collection of records, and the assessment team would set a predetermined data quality standard, and then you would see if those lots meet that standard or not. And those that meet that standard can be skipped and they don't have to be monitored. And I think the advantage of this really is, apart from it being quick and expensive and something that you can do frequently, so we have quarterly or semi-annually for the periodicity included here. But it's also useful for identifying sites where there are issues and there are data quality challenges that you can then target for more extensive data quality assurance activities such as routine DQAs. In terms of the tools, just to say, there are very good tools already out there developed by partners that we're suggesting countries look at. And so there's this manual that's developed by Measure Evaluation that goes into the methodology. We do recognize that some of the challenges in using this is that there is less implementation experience of applying this approach to viral load. It's often used for HIV treatment data. And sometimes the sampling and setting the predetermined data quality standard can be a little tricky. But there's very good guidance out there, and also a series of Excel tools that countries can use and adapt. And then just to finish off, again, this is an activity that many countries are implementing. So the fourth activity was included in this menu of options. And it's not to say that it's an either, but actually a number of these activities might be appropriate within a country context. So the fourth activity is routine site level performance review or data review. So this is where the clinical team comes together, reviews the completeness of the data, tallies the results from the registers and compares them to the monthly total that you have in a different data source. It could be the electronic medical record or laboratory information system. And also looking at turnaround time results as well for viral load test results at the same time. And really the benefits of this is, in addition to being sort of rapid and frequent, it's more that it enables the data to be checked and corrected at source before it gets reported up. And it enables the facility really to take ownership and to develop and plan to improve their patient monitoring systems. And it can very be integrated into the performance reviews that many facilities are already implementing in terms of, the activities around continuous quality improvement to improve service delivery. So it can be built into that. Obviously, it does not benefit from the external monitoring and the supervision that you get from the other activities. In terms of implementation, ideally, we're recommending that all facilities should implement this as part of the review of their performance. But if it's not feasible to do so, certainly in the facilities where previous data quality assessment exercises have identified issues. And this is something that can be implemented on a monthly basis. So this pretty much summarizes what I just said, but just to say, we're suggesting that the key indicators for HIV testing and treatment should be tallied and looked at alongside the viral load indicators during this exercise, so that the key services in the entire HIV cascade can be reviewed at the same time. So this, just to round off, just shows visually the time and cost and human resource requirements. And as you would expect, we have routine DQAs being the most costly, human resource and time intensive, and the monthly site level routine reviews of data being the least. Just a word on routine DQAs. We know that a number of countries already are implementing these for HIV treatment data. So we're suggesting, rather than having standalone exercises for treatment and for viral load indicators, we're saying that they should be brought together and done in one exercise. And I know from my experience of working with Kenya and supporting the Kenyan team, they do this already, and we'll hear more from Faith about this. So just very quickly, just to say, we also have some tools to enable the graphical display or dashboards of the data quality assurance activities, as that's a very helpful way to talk through the results as part of the site brief, and also to leave that with the facility. So we have tools for each of the four different activities that countries can adapt. They can enter their own data, and it will visualize their data in these different charts that are shown here. We also have templates for the site improvement plan to address the data quality issues. I think many countries are familiar, and what we try to also include is something that we recognize too, that we often develop these plans, but it's the follow-up on the implementation is sometimes lagging. So we've tried to also include a column to really encourage the relevant levels, whether it be the district health management teams or the levels above, to make sure that the recommendations for that site are implemented and they have the resources and the support to do so, to address these data quality issues. And just to say, there's also a template for putting together a summary report to make sure the results get to the relevant focal points and partners at all levels. And finally, I think on the request of countries, we've also tried to develop generic budgets for each of the different activities included in the menus, which countries can then adapt, recognizing, of course, the unit costs will vary, but it can be helpful to have at least a breakdown of the budget items and some of the assumptions to really help countries select the options that are, or the activities that they feel will be suitable for their context. So those are the tools. So just to very quickly conclude, I know I'm running over time. One of the things that we've tried to give space and to think about is how to follow up on the different data quality assurance activities. So with a view to working towards developing long-term data quality improvement strategies. So if you've implemented a routine DQA, what should that trigger? And just to try and get some thinking around that. And so we've included in the tool, I think 5 examples or scenarios. I'm just going to show you one very quickly. I won't go through the details in the interest of time. But let's say you do a DQA, a routine DQA, and you find a discrepancy between what you calculated in your viral load suppression indicator versus what the facility reported or the site facility reported to the national level of 5 to 10% difference. So what should that trigger? So in this example, we're suggesting that you might then go on to conduct in the next quarter data quality monitoring via supportive supervision. And then depending on whether the site fails or doesn't fail, failing meaning has significant data quality issues, that will then trigger a series of actions, which not only include the data quality assurance activity, but could be training, it could be mentoring and support. And just to say, even if a site does not have significant data quality assurance, data quality challenges, doesn't mean that they can't benefit also from additional strengthening in terms of their capacity for data management or reporting or for mentorship. And then, in the following year, you can then conduct a TQA in the sites that you didn't reach in the last one. So that's just one example very quickly, but there are others. And just to conclude, and to give you our thinking about where we're going and what we'd like to develop. Certainly, we're recognizing that we have these menu of options that we're suggesting, but some of these might not be appropriate under the context of COVID-19, where we can't go into facilities in the same way that we would. So thinking about different strategies to deal with in the medium term, the challenges that we face with COVID-19, and we'll hear from Faith to see how Kenya is thinking about that. And then thinking about the sequencing and the flow of the different activities and how they fit into long-term data quality improvement, and not just looking at the assessment or the assurance of data quality, but there are other activities. It could be training, it could be mentoring, it could be supporting data entry that feed into an overall strategy. And finally, just to end, to say that this is the space that we're thinking about and we're taking forward. So right now, we've just started the work to develop the WHO Consolidated HIV Strategic Information Guidelines. So bringing all the guidance together for strategic information. And there will be a section with recommendations and guidance on data quality and where to take this, and in particular helping countries to think through what are the key elements that should go into a data quality improvement strategy or plan. So I'll end there. Apologies for running over and speaking quickly, but just to acknowledge the many different participants or individuals who contributed to this joint tool, and to say I'm very much looking forward to hearing from the participants on the line, their experience of implementing viral load testing data quality assurance activities. So with that, I'll stop and I'll hand over to you, Faith, and apologies for running over.
Thank you, Hiwot, and welcome, Faith. And please, participant, feel free to put your question in the chat box. We'll address them toward the end of the presentation. Faith, welcome.
Thank you, Michael. Thank you, Hiwot. Let me share my slides. Michael, you can confirm if you can hear me.
Faith, we can hear you. Yes, we can hear you. Please put them.
And you can see.
Yes, put them.
Yeah. Doing that in a second. So good morning, good afternoon, good evening, everyone. On behalf of the Kenyan team that looks at viral load data, I'm going to do a short presentation in regards to data quality and some of the data gaps that we have identified and the interventions that we've been able to put in place. So this is the outline of my presentation. We'll have a brief background of the country in terms of HIV burden, scale up of viral load testing, data quality improvement strategies, data management systems that are there in place, experience of implementing data quality activities in the context of COVID-19, and we'll have a summary of the presentation. So in terms of HIV burden, Current prevalence is at 4.5. This is from the 2020 estimates, it being higher among women, which is 5.7, and 3.1 amongst male. For the current number of estimated people living with HIV among adults, we have about 1.4 and 106,000 for children aged between 0 and 14. In terms of new infections, we can see that majority of our new infections are in falling among the adults, which is about 34,610, and we just have about 6,800 children who are reported to have new infections. So every year we have about 41,000 new infections. For the 90 coverage, here we're looking at coverage. Where are we at? This was as of December 2020. We have 81% in terms of identification, 81% putting the ones that have been found on ART, and 76% for those that are virally suppressed. This diagram, sorry, could be too busy, but it's just a diagram to show you the milestones that we have moved from 2010 to 2020 in regards to the development of the VL and EID system. So its birth took place in 2010 as a system, and this is when it was developed with support of just the dashboard, which was mainly looking at logistics and the turnaround time. In 2011, we got to have the VL development of the dashboard that was also looking at logistics and also turnaround time. So very little support and basically improving on what had been developed at the initial stage in 2020. In 2013, we got to revise the dashboard, and we moved further to improve on the indicators that are related to viral load. And this was a great improvement on the dashboard. In 2015, we revised the EID component of the dashboard to indicate the HAE validation and other PMTCT indicators. In 2016, we brought an element of remote login where all the facilities that were able to collect samples are able to send in their results directly through to send in patient information through remote login as the sample moves to the testing laboratory. Then in 2017, there was implementation of return of results alerts to the clinician, as well as the caregiver, so that they can be able to give feedback to their clients. 2020, there was growth from what the system to integrating it further with the current EMR and also the aggregate system, which is KHIS, formerly called DHIS. So because we have a lot of information that we require for use to especially calculate the 90-90-90, there was need to have it integrated with our aggregate system, that's KHIS, as well as be able to have longitudinal data about our client. And that is the reason why it was integrated with the EMRs. Then we are also looking at creating a facility registry for ease of exchange of information for clients between different systems that are sitting at facility level. So this is the graph that shows uptake of viral load testing from 2012 to the current to 2020. There have been tremendous improvements over the years, and we can see we are currently, by the end of 2020, we were at 1.3 million people who had had a viral load. And I must say there was, from what you'll see in my next graph, you will see there was some interaction due to the COVID pandemic, and that is the reason why you see the numbers had a slight decline. However, after the country normalized, the uptake of viral load went up. So the testing laboratories that are currently in operation are 10, as you can see them from the map indicated on my left. And also you can see the names of the labs and their placement for the country. So various facilities have been able to be mapped upon the 10 labs. From the list you can see here, we have the 9 national lab, and then we have 1 hub, which is the EDAP lab. making them total 10 labs that are currently doing viral load system. So all these 10 labs are the ones that are able to serve our 3,500 ART sites, which are currently in functional and offering care and treatment for HIV clients. Out of the 3,500 sites, we have about 1,422 that are currently using EMR for patient care, and a patient load of about 75%, which I think is quite representative for the country. In terms of data management tools that are currently in use, we have several of them, but the highlights of today is the viral load request form, which is like the primary source document for viral load testing. It is the one that is where the information of the patient is filled, and it is later on shared to the lab to be able to conduct the testing. And once the results are out, the printout of the results returns back to the lab through the electronic system. Then we also have high viral load registers. This is not officially in use at all facilities, but the government is planning on how to have this in place. Currently, what we have is partner supported, but I think it's a vital register to put in place to enable us monitor patients who have not virally suppressed, and you can continuously have their information recorded. So our current system has got several functions. One, it has historical data. As you see, it was put in place in 2010, and until today, it continues to be utilized. And as a result, we can be able to tell information about patients over a period of time. It's also used for tracking and storage of specimen, and it's also used as an inventory for management of the entire laboratory stocks. It also gives us workload management in terms of how we are progressing in the various aspects of work that are related to viral load testing. It also acts as a serve and as an interface with other systems, and there is exchange of information between the various systems that are currently existing at our facilities for offering HIV care and management. So the milestone with the current system is that, one, we have been able to integrate our viral load database with the SMS platform, and as a result, we are able to share the results of the clients to the clinicians and the caregivers on time. It has also been able to be integrated with the national EMR system for exchange of information, and this eases care and management of the clients by the clinicians who are offering the services at the facility level. And as I said earlier on, we've also been able to integrate it with the national reporting system, that's KHIS, formerly called DHIS2, for purposes of providing data that will be used to make some of the calculations, especially around the 90-90-90 cascade. In terms of some of the best practices that we have as a country is that we have the lab clinical interface initiatives. For instance, I say there is exchange of results between the system and the clinicians, and this makes it easier for patient management. This follow-up on rejections and redraws from the samples that have been collected, and there's utilization of the right tools for data completeness. Then the other thing is we have weekly review of sample workload. The labs are looking at the backlog and refer to that. The labs with the backlogs refer samples to designated backup labs to be able to reduce the turnaround time. So at a glance from the system, you can be able to see how are the labs performing, what is the workload for each lab, and in case there is need for assistance from another lab, you can be able to tell, and you can be able to share the work so that you can be able to reduce the turnaround time. There are also different platforms for results access. We have the online access from representative laboratories. We have the national dashboard, which tells us a lot. You're going to see some of the screenshots that we've been able to take. We have facility emails where they're able to receive their results. And then we have SMS, which goes to the clinician, and a phone at the facility level, and they are able to review the results of the clients once the tests have been done. Sorry, just allow me to. Michael, let me stop sharing for 1 minute. It's refused to move, but I believe it's gonna do.
All right. Do I project from my end?
Yeah, if you can please just proceed and project from your end.
Let me see. Can you see my screen?
Yes, I can.
I hope I have the right one. I have not skipped any, did I? But there?
Yes, I guess, yeah, it is.
Okay.
Yeah, let's move back
All right.
to the
The
previous
previous one?
slide.
Okay.
No, previous.
Okay.
Next.
Oh, really? Yeah.
The next one, prior to this one. Yeah, thank you. Okay, so yeah, this is the next. Yeah, that's where we are now. Best practices. No. This we had already covered. Let's move on to the next one.
There. I think there's a lag behind. I think there's a lag between the projection. Can you see it now?
Yeah, but now the next slide.
I'm showing best practices. That one?
Yeah, that one. That's where
All
we
right.
are now. All right, thank you. So the other best practice that you have is remote login. As I have said, all the sites where the samples are being collected at the lab level, the officer at the laboratory is able to do remote login. And by remote login, it means they have an app on their computers, on their phones, where they key in the patient data and patient information. And this is directly shared to the lab that is going to do the test. And this has really improved on data quality, because there is no need again for the same information to be re-entered by the testing laboratory. It has also improved on sample and results tracking by the clinicians, and this has also reduced the turnaround time because it leads to prompt interventions. We also have active committee of experts that are meeting every quarter to be able to discuss the performance of viral load, identify some of the challenges and the gaps that have been witnessed in their quarter, and be able to have action plans to better improve on the quality of VL service. Next, please.
Oh, that's refused also. I have no idea what field is going on.
I am also not certain what's going on, so.
It refused to move again. Sorry about that.
No problem.
Let me try one more time.
Okay.
Not yet. It has refused again.
Okay, so let me just try and share from my end.
I'm sorry about that.
No worries. Have you been able to share again?
Let me see. Can you see it? Yeah.
Yes.
And we need to hurry up a bit.
Okay, so for the data quality improvement activities, what are the strategies that we've put in place? We launched our data quality assessment guideline in the month of April, and some of the highlights in the DQA guideline are around the viral load, and it's mainly guiding us on how to conduct DQA at every level of service. It's got a session which looks at abstraction, and by abstraction, it means we are comparing different sources of data, and then we are seeing how we're performing for the various aspects of data. So for viral load, we have a section under the care and treatment area where we're looking at the number of clients having a viral load test and the number of clients that have been suppressed. And for this, we do it as an abstraction, and we are able to compare our various sources of data, beginning from the primary document, which is the patient's green card. And then we're also looking at what has been entered into the EMR and eventually at the lab level, and what has been reported nationally through the system. At the laboratory, we are looking at two variables. That's number of viral load tests sent to the testing laboratory and number of viral load results that have been received. Next, Michael.
It has hung again. I don't know what is going on with the presentation today.
I don't know.
Uh,
Can I try share from my end?
Try one more time from your end and see. I'm sorry about that, participants.
Okay, so you can be able to see it.
Yes.
Okay,
And
let
we
me
have.
just.
And,
Okay, so you're good.
yes, we are good.
Yeah. So the next thing is data quality improvement activities. The other thing we have is data alignment meetings. So we occasionally conduct desktop reviews of our data. That's looking at the data from the viral load system. And then once we identify the gaps, we have meetings together with our the team from the subnational level to just be able to align our data. We do technical assistance to the subnational level, or what we call support supervision. We have client notification on results status through SMSs. This is a pilot that is currently being done just around the AMPAD sites, but as a country, we are planning on how to scale up this return of results to the clients. Then we have emails and SMS notification to clinical staffs on clients' results at the facility level, which are immediately submitted once the results are out. Some of the challenges that we are facing is lack of a unique patient identifier. And as a result, we are really not very accurate on the numbers that are reported. The other thing is the information or the communication that is shared to our patients is through SMSs, which again reduces the turnaround time. And one of the lessons that we have learned is that frequent data quality checks improves on the quality of data over time. And this we can attest to because we have done it occasionally. So I will just quickly flip through this. These are some of the data quality gaps that we see from our VL system. You can see there are quite a number of data incompleteness. We have an issue around the validity of our data where they're giving us 100% VL uptake, which is not the instance. And then the other aspect is that we can see we have missing ages that have not been documented. If you look at the far left-hand side of the screen, then we also have regimens that are missing that haven't been filled into the system. And these are some of the areas that we are still streamlining and ensuring that this data is completely filled in the system once the patient information has been documented on the forms. This is just sharing also some of the outputs that we are able to visualize from the systems. We can be able to tell with the tests that have been done and the results that have been received and the proportion of patients that have been suppressed. And in terms of the levels, we can be able to tell how many have low-level viremia and how many have LDL, as well as those that are not suppressed. The above two screens, one is from the viral load system, and the bottom screen is from the EMR, where both of them are giving us a viral load suppression of about 96%. And it's good to know that this is not a one-to-one number comparison because we do not have all our sites operating on EMR. However, we have all our sites reporting to the viral load system. These are also dashboards to see some of the quick glances that you can have in terms of what has been done for VL. And you can also be able to see by the various age groups, how is the suppression rate, and for those that are not suppressed, which is more amongst between the male and the female, and also which month has got fewer patients not being suppressed as compared to the other months. Then in terms of COVID-19 effects, definitely at the start of 2020, we had quite some improvement in terms of viral load testing. But however, between the month of April and June, there was a decline of about 30% thereabout in terms of VL numbers. And this affected our numbers in the year 2020. However, after June, the numbers picked up and consistently until December when there was a decline. But if you look at what is happening in 2021, you will see that the number of tests being done has continued to rise over the months in the current year. So when that was realized, what we did is to put in circulars and communications to our subnational level that was giving guidance in regards to the various aspects of HIV, STI, and VH services. And particularly for viral load, there was in the circular contained information on the need to prioritize VL for new patients, for the mothers and then for all those that were suspected to have treatment failure. It also emphasized on the need for reporting on all HIV-related data, and it should be done as per the guided timelines. And it's good to report that during the COVID period, we really did not have challenges with the reporting rates. However, the numbers could have declined because there was a decline in terms of service seeking care at healthcare facilities for all the facilities in Kenya. The other strategies that we did put in place that time were very frequent virtual technical working groups and committee of expert meetings to discuss some of the gaps that were being identified, and also make it clear in terms of operations of viral load services. And also we had follow-up calls both to our clinical team and also to our clients to be able to ensure that they come back for their viral load test as it has been assigned or as it has been documented in their clinical notes. So in summary, data quality guidelines are available and have a VL component. It might not be comprehensive comparing to what Hiwot has just presented, but again, it's subject to revision. And I think as a country, we look forward to developing a viral load data quality guideline. There are also data quality corrective measures in place to ensure improvement of the data that we are currently collecting at our facilities, and this include desktop reviews and county-based data alignment meetings. And then during the COVID-19 pandemic period, we have been able to share some communications to our subnational levels to ensure that services continue being offered to our clients in line with what the guidelines are saying. And then technology has also come in, and it has really been embraced to support data quality aspects. And it is on keenly looking at aspects of timeliness, accuracy, and reliability of the data. And that's why we can be able to see that we have two different systems collecting the data. But however, when we look at our suppression rates, they are quite close from either of the system. So thanks, and I would like to acknowledge the team that's put up this together. That's the M&D subcommittee team. Thank you for the work that you made us present today, and also recognize the efforts by all the stakeholders that are involved in HIV care and treatment. Thank you for listening to me, and keep safe. Over to you, Michael.
Oh, thank you, Faith, for that very elaborate presentation. I'm conscious of time, and we have about 3 minutes before the top of the hour. Fortunately enough, I've seen majority of the question that have been posted within the chat box. We have responded to a number of them. There was a question on whether the presentation will be made, whether the tools are available, and I think Hiwot has tackled that. Being very conscious of time, I'm just going to ask the participants to allow us to go through over by about 2 to 3 minutes. I would want basically to ask a question, and this question goes to Hiwot. Availability of data, mainly at national level, especially for the cascade of patients who are not virus suppressed, remains a major gap. And recently, we have also been having issues with availability of data on those patients who have been referred to less intense model of care. I would want you to highlight whether the current recommended tools, how the current recommended tools by WHO are addressing that gap. Thank you, and over.
Thank you, Michael. So if I understand your question is, do the current tools look at the data quality challenges for patients who are unsuppressed? Is that right?
Yes.
And yes, very much so. So it's the checks are looking at the availability of data entirely, and then breaking that down to those that are unsuppressed and those who are suppressed. So it does not, it's intended to capture all, and also on the service delivery side as well, as I'm mentioning, and for the tools that we have for supported supervision, that also looks at some of the issues and challenges for unsuppressed patients. So yes, we've tried to give that space and thought, because that is a key group that's being missed.
Thank you, Hiwot. And maybe the other question I would have, and maybe the guideline or the recommendation that we would make to countries that are represented here. The tools are very elaborate in terms of what needs to be checked and the frequency. And I like the fact that you have also looked at the cost implication that goes with every kind of intervention that you're putting in place. maybe I would want you I would want to hear a little bit more. What would be your recommendation to a country that is currently not implementing data quality interventions? How would you advise them to roll out these interventions and tools?
Michael, excellent question. That you're asking the tough questions. If a country has well, I mean, if they're in the position where they have not done any activities whatsoever, I would suggest starting with the routine data quality assessments, because you've done no verification at all. So that is the most extensive activity of all. And I would suggest also not just to look at the assurance, but to also then think about the other activities that Faith also spoke to as well, because it's not just about the assessment, but it's all the other activities, the training, the mentorship, the data alignment. You know, those would be the key pieces. And that's what we're hoping to develop a bit more as well for countries, to say, what are all the different pieces that you should think about? But certainly if you're starting from scratch, yeah, bringing together partners and starting with a data quality assessment where you do all the checks, and then you can tailor down, and as you continue to implement, you can look at some of the more less intensive, less resource intensive activities. That would be my recommendation. Can I also just respond to one quick question that was in the chat, which is a very good question, that is about looking data quality checks for aggregate systems, if I may, Michael, because we did get.
Yes, please go ahead.
Because that's an excellent question. And I think Francis picked up on the fact that I was mainly talking about the data quality checks that you would do at the level of the patient monitoring system or the viral load database. But we do have aggregate data sources as well. And it's not an either and either situation, it's a both actually. So there are approaches. So I know for DHIS2, they have a very good manual on how to do data quality assessments and checks for the aggregate system. But bearing in mind that for most countries, these aggregate systems only from the viral load testing data only include viral load suppression. And we still need to go back to the underlying data sources where all these data come from, and make sure that we're also assessing and doing the work on the underlying data system. So it's both are very important and shouldn't be forgotten. So we still need to continue to do the checks as well at the aggregate level. Thank you.
Yeah. So thank you, Hiwot, for that. I was coming to that question, and probably I would have tied it up with a question that touches on EMR. You mentioned that the concordance between the EMR and the manual remains a challenge. Do the tool address that, whereby I can compare what my EMRs are saying vis-a-vis what the paper-based systems are saying in an event a site is implementing both systems?
Yes, that's exactly it, Michael. So the tools are designed to, when I talk about cross-validation, Faith also mentioned the activities that they're doing as well. When you do your abstraction, you then take a data element. So you could take your viral load test result, your last result and date, and see if it's consistently reported in the EMR compared to the paper charts, and see if there's consistency. So that's what those cross-validation checks are designed to do, and the tools are designed to enable that.
So thank you, Hiwot. Thank you, Faith. In the interest of time, I don't think we are going to address another question. We are 2 minutes above time. But before I let everyone go, I'm going to invite Nancy to make any comment. Nancy is the LabCoP lead for Kenya, and then Faith, and finally Hiwot, you make your closing comments. Thank you. Nancy.
Thank you, Mike. I think where I am, I don't know if you can hear me, but I'm happy. Yes, I think what Faith has shared is really a representation of what we worked on as Kenya team, and I think we don't have any question unless we get questions from other people. Thank you.
Thank you, Nancy. Faith, any closing comments?
Thank you, Michael. I think from the Kenyan team is to appreciate the opportunity that you have granted to us to be able to share our experience, and we look forward to sharing more and also learning more from other counties. Truly appreciate and thank you, everyone.
Thank you. And now finally to Hiwot.
Just again to add my thanks to Faith, and to say it's a pleasure to hear from all of you and your experiences and your questions, and to have Faith's presentation to really bring us practically to the ground to see how these tools, these different approaches can work. And my contact details are in the email in the presentation. So if there are future questions, we'd be happy to continue the discussions offline. Thank you very much.
Thank you so much. Thank you, Hiwot. Thank you, Faith. Thank you, Kenya team. We really appreciate everything that you have put together in the presentation. We'll be sharing the presentation immediately after this. And so good morning, good afternoon, and good evening, colleagues. And it's goodbye from me. Thank you.
Thank you.
Thank you all. Have a good day.
Okay.